All right, everyone, we're going to go ahead and get started here. So, um, welcome. My name is James. I'm the technical content specialist here at Ravenna, and this is our Trends in Neuraxial Anesthesia, Key Developments in Ultrasound Guidance, Training Simulation, and PDPH webinar. This is the second webinar that we've done, by the way. I don't know if there's any repeat attendees. We did one earlier in the year, back in the summer. And these two webinars have been based off of some quarterly reports that Ravenna has been working on, basically covering trends and developments in the neuraxial anesthesia field. And for our presenter today, we're really excited to have Dr. Hilary Gallin here with us today to cover some of these developments. So she's going to discuss some of the content of this report, and then after that, we'll have some time for a bit of Q&A. So if you'd like to submit some questions here, feel free to enter those either in the chat or in the Q&A box at the bottom of the screen. So without further ado, Dr. Gallin, take it away.
Thank you, James. Thank you for having me, and thank you all for attending. I'm really excited to talk about the current state of neuraxial anesthesia, some evolving trends. Looking forward to your questions at the end. So by way of training, like I'm sure many of you in the audience, I'm an obstetric anesthesiologist. I work at a very busy academic medical center in New York and have done my training previously in Missouri and Boston, and now call New York home. We'll start with a few things, just the current state of affairs. Uh, when it comes to neuraxial techniques, I know a lot of us do landmark techniques, but um, these techniques are becoming more challenging when we think about the rising patient complexity and the kind of the busyness of our labor floors. We obviously rely on these techniques quite a bit for spinal anesthesia, for laboring patients with epidurals, and they're essentially the bread and butter of our obstetric anesthesia practice. Evolving safety standards and the acceleration of adopting ultrasound are really reshaping the way that we think about procedural precision and redefining the way we think about training. Obviously, none of us want to have any complications, including, butt taps or unintended dural punctures. And I think we're really thinking about our practice in a really evidence-based way and thinking about what's our data and how do we improve that in a meaningful way. The other part that I'm excited about is really thinking about the role of education. We are seeing, in addition to having models, more simulation-based education, thinking about standardizing these protocols, and thinking about how to consistently train, whether it's our nurse anesthetists or our residents, really thinking about how to get everybody up to speed really quickly in the spirit of patient safety. Let's talk about a couple of patient trends. First, our patients are, just like the rest of the nation, are becoming more obese. We have 40% obesity rates, and I'm sure depending on where you practice, this number may actually be even higher depending on the part of the country. And unfortunately, these high BMI patients have significant complications, are significantly more complicated, excuse me, when placing the epidurals. It's harder to palpate. They're often deeper, and it just increases the complexity of the procedure. And that's where I'm really excited about RIVANNA and their current products. So let's go back to these high BMI patients. So why is it so hard? I know I can think about my own experiences. Today, I had a patient who had a BMI of 50, and she didn't have a favorable airway. And I knew I really needed to get this combined spinal epidural in before her C-section. And it's a complicated patient interaction. We see that patients have a lot of anxiety around these procedures. We see that these procedures actually just take longer because we can't palpate as well. We have lower first attempt success rates. And so therefore, we're trying more times, which is one, frustrating for the patient, it's frustrating for the provider, and increases your chance of an accidental, an unattended dural puncture. We often need more needle insertions, the patients are more uncomfortable, and we see an increased risk of wet taps. And then furthermore, when we think about managing a busy labor floor, I need to efficiently be able to place these epidurals or spinals. Um, if this procedure takes me a significant amount of time, it disrupts the rest of the workflow. And so having something that can be a reliable system that improves the first pass success rate, which decreases patient anxiety, which increases our satisfaction as providers, is something that I'm really excited about. And so this is where RIVANNA comes in. They have done a number of studies. I'll highlight one now, which is they looked at high BMI patients and they looked at first insertion success with their AI-assisted ultrasound technology. And it's really staggering to see how much of a difference it makes on their first pass success, being able to um, have your procedure be guided by ultrasound imaging. Um, it really changes the game. This really has the potential to become the standard for high BMI patients or patients with scoliosis or kind of complex anatomy instead of relying directly on palpation. And so there's actually more evidence supporting the role of ultrasound in general. So we see an 84% increase in the likelihood of first pass success when using it pre-procedurally. So this is essentially using an ultrasound probe to just map out your level, midline, any rotation, compared to 47% just with pure landmark techniques. When we look at using AI-assisted pre-procedural ultrasound, that's where RIVANNA's Acuro product comes in. We're actually able to see the spine in a more 3D model and really understand the curvature, um, the change in angle, and we see again a very significant increase in first pass success rate. What I like about the AI assisted technology is it can be very hard for a novice user to just use a regular ultrasound, using a plain curvilinear probe. It takes some technique and some practice to really understand what you're looking at, in addition to being a master of the actual neuraxial anesthesia. And so being able to have this AI assisted technology walk you through and kind of decrease the barriers to your own understanding is a really exciting advancement. And what's most exciting is not just using it pre-procedurally, but thinking about using ultrasound in real time, being able to actually see how your needle is moving, where you are in space. And that's what I'm most excited about, selfishly, as an anesthesiologist, which is being able to not just map out someone's anatomy, but to see what I'm doing in real time. We have this in other procedures. So if you do nerve blocks, we now have real-time guidance. We have video assisted laryngoscopes. We're moving in this direction in a lot of ways, but until their technology came around, it actually is not possible to do real-time ultrasound guidance. And so I'm most excited about that. The other component is not just the actual procedure, but thinking about how we can transform training and success for our trainees. It's neuraxial anesthesia is a very, I think, frustrating procedure as a provider to teach because you can't put your hands on the patient at all moments. You can't see what's happening. And so being able to train um, trainees in a safe way is really exciting. For trainees to have more simulation-based training to understand where they are in space and kind of how when they move their hands, how the needle adjusts and where they are with respect to someone's anatomy, I think is a real game changer. And so when we think about it in two ways, first is the AI-assisted ultrasound imaging, it really can strengthen training by giving learners more opportunities for hands-on practice with real-time feedback and clear visualization of the anatomy. When it comes to the simulation, we can also pair this with VR tools and thinking about how to really standardize the learning process for these learners to make sure that you have the best trainees on the floor and ensuring the patient's success. So when we look at the evidence supporting the simulation-based training, it's really quite staggering. So there was a study looking at tibial nails, and they saw a 230% improvement when they incorporated VR training, being able to really, put yourself in the situation to practice what it would be like to place it before actually moving to patients. And that's just really exciting when you think about what that could be like for neuraxial anesthesia, especially when you think about, I'm always very sensitive to our patient population. On OB, we have young patients who's often this is the very first interaction with the medical system or having a major procedure. They are nervous, obviously, as patients, as new moms. They're in a lot of pain, and anything that we can do to, flatten the learning curve, I'm really excited about. So we also see VR augmented anatomy training, improving technical accuracy. We also see this trend across a number of schools in the US, and that's where I see this product being helpful, which is being that link between the desire for training, the trend in training, and then actually having a device to use for that training. And we've seen that these simulation programs really have long-term impacts, not just with the training, but thinking about maintaining skills among infrequent practitioners. So if you're rotating, if you don't do OB normally, being able to get up to speed really quickly in a way that you feel comfortable. Reducing variability in epidural proficiency. Again, some people do epidurals all the time. Other people do them once in a blue moon when they're on call. I know there are other procedures that I don't do, and I would love to have an opportunity to train myself right before I know I'm going to be on call. We look at these programs have decreased complications, they've improved patient satisfaction, they've decreased procedure times, and it's also meeting the requirement for board examination professional requirements as we think about going forward in training. I'd like to take a moment to really talk about post-dural puncture headaches. And I'm hoping that this trend in ultrasound guidance and AI guidance can really make an impact, because this is probably one of the complications that makes me feel the worst as a provider. So just to recap, a post-dural puncture headache is caused by leakage of cerebral spinal fluid from the site of an accidental dural puncture, leading to a drop in intracranial pressure and this characteristic positional headache. So moms often will say, when I'm lying down, I feel fine, but when I sit up to eat, to eat or to feed my baby, I get this, really intense neck pain or, back and neck pain or forehead pain that's truly debilitating. So some of the risk factors include using a large gauge or a cutting tip needle. So we've switched to pencil point needles or Whitaker needles with the spinals. But if you wet tap somebody with your TUI or your Weiss, you're really leaving a large hole. Young patients are particularly susceptible. So we think about our young laboring patients. Women, especially pregnant women, are at increased risk. And so we have this population of patients that are really kind of primed to get a headache after a dural puncture compared to, if you had an accidental dural puncture with a 90-year-old getting a procedure. The high BMI actually can be protective to it due to the increase in epidural pressure and epidural fat. However, these patients are at risk for more wet taps. Multiple puncture attempts, again, we talked about that with obese patients. And then patients who have connective tissue disorders, patients with Ehlers-Danlos, Marfan's, have an increased risk of a headache. And so some of the things that we can do to prevent post-dural puncture headaches include using a pencil point needle. This is going to separate the fibers of the dura instead of cutting them. We can do everything we can. We can optimize patient positioning to achieve the right alignment and decrease rotation. But the parts that I'm really excited about, because we do 1 and 2 no matter what currently, and that decreases the risk somewhat. But what I'm most excited about is 3 and 4. So having this AI assisted neuraxial ultrasound imaging, um, really may improve anatomic localization, understanding where you are in space. You're not guessing, am I off to the right? Am I off to the left? What am I hitting when I hit bone? You can really understand where you are in space and how to make those micro adjustments to lead to first pass success. Um, and finally, thinking about this opportunity of simulation-based training programs, allowing you to be that much better when you actually first meet a patient, improving the patient experience, but also improving learners' confidence. And so again, when we think about post-dural puncture headache prevention, we think about the needle, we think about ultrasound guidance, we think about proper positioning. And when we think about incidents, hopefully you have an uneventful neuraxial anesthesia placement and everything's fine. When we think about these patients who do have a post-dural puncture headache, we have a couple options. The first is we can do mild conservative treatment. We can have patients rest. We can give them fluids. We can next kind of escalate to caffeine, gabapentin, Fioricet, these oral medications that can hopefully help with the headache. And unfortunately, when we have patients who are so uncomfortable and have failed these measures, then we need to move to a blood patch. And while blood patches are extraordinarily effective, they do put patients at risk for the same issue, which is another accidental dural puncture. Um, there's a risk of infection with the actual blood patch, and it's really hard, at least in my experience, to convince a mom who just had a baby, who's extraordinarily uncomfortable, who had a complication of a procedure, to basically undergo the same procedure again and say, "I hope this time it will be better." And so anything that we can do to avoid this is really exciting. The other part that has always stayed with me was the new literature that's coming out, looking at the long-term effects of post-dural puncture headaches. While we can fix the headache in the near term, some percentage of these patients are going to go on to have chronic headaches. And so when we think about what we can do to prevent, to optimize for success, prevent complications, it's not just the immediate experience of this mom can't sit up for to nurse her baby. It's I've now given her chronic headaches for a period that frankly is undefined. We've studied it. A lot of the studies show 18 months, but we haven't really determined how long it really lasts. And so when we think about the evolving landscape of neuraxial anesthesia, there are several things I'm really excited about. The first is thinking about the demands on our time, our resources, and our expertise. So we see that patients are becoming more complicated. They're having rising obesity rates, in, increased procedural complexity. So I had a patient today who had a car accident and had fractured her spine and was never corrected and had all sorts of anatomic challenges. And these patients are getting pregnant. And all of this just points us in the direction that we need better precision and better consistency in the same way that we've seen other procedures evolve within anesthesia. Patients have higher safety expectations, and they're demanding more of us in terms of understanding the evidence and understanding the success of our procedures. When we think about limitations of traditional training, we've learned landmark-based techniques, we've learned on static models, and depending on where you practice, you may have very different experiences. When I was in medical school at WashU in St. Louis, that was a very different population than the Upper East Side of New York. And depending on where you practice, you may develop different skills. But the idea that we could really standardize this and give everybody a similar learning experience to get them up to speed is quite exciting. We think about, again, the traditional training is that when we have more high-risk patients, we have more failed attempts, we have more complications. Learners often don't get these procedures because the attending steps in because it's more complicated. And so being able to give somebody the experience of really understanding, what is scoliosis and where am I in space and how do I think about training is truly a gift. When we think about evidence-based modernization, we think about simulation, we think about AI-assisted ultrasound, standardizing protocols, and making this technology very user-friendly. I think that um, you know uh, the older physicians in my practice when I was in residency weren't as familiar with ultrasound, but it was part of my curriculum as a resident. And so I'm very excited about the opportunity to decrease the barriers for everybody who uses technology for patients to benefit. The technology also enables consistent skill acquisition. We can give everybody a similar experience. We can watch them do it. We can really understand in the same way that we do with other procedures. Um, we can make sure that everybody has reached a certain standard before practicing on before trying it on patients, and making sure that they have been trained throughout their lifetime as a physician, and are up to speed. And then thinking about the impact on practice. And this is the part that I'm most excited about, which is really thinking about enhancing safety, efficiency, and the patient experience. We all want to do the right thing for our patients. We want to help them. We want to make them safe. We don't want to give them any complications. And especially on OB, we want to give them a really good experience. We know that they're nervous. We know that everyone's Googled something about an epidural and has a horror story from a friend. And to be able to say, I have something new that I'm going to use, I think is incredibly makes patients feel really optimistic. They're very accepting of this technology. I often say, I'm going to ultrasound your back like we've ultrasound your belly for the last 9 months. And patients are incredibly excited that maybe there's something that we can use that will improve their experience, even if they had a baby 2 years ago. Um, and and they had a difficult experience. I think a lot about the founder's wife, and her story about her challenging epidural, and think about what this could have done for her in the moment. It also supports competency development, accelerates learning curves. It really makes sure that everybody's up to speed um, before they start. And so when we think about the path forward, there's a lot to be optimistic about. The first is thinking about the convergence of innovation, evidence-based medicine, and being able to know what is the most effective way to train somebody, how we can improve our first pass success, and how we can put it all together to improve the patient experience. Um, with advanced visualization, intelligent guidance, all of this is becoming much more accessible. You don't need to be an expert in reading ultrasound. It's especially hard on some of the high BMI patients when the pictures are not super clear. And this really decreases the barrier to accessing the technology. I'm excited about thinking about how we can collaborate as clinicians with educators and industry to make products that we actually want to use. I've enjoyed working with RIVANNA, and one thing I really appreciate about them is that they bring clinicians in quite a bit, and they really want to understand how we would use the technology and what would make our lives easier. And I think this collaboration where we have this conversation early will only make these products better and make our lives better. And then thinking about, embracing these advancements, we can ensure that every patient really benefits from the highest standards of skill, consistency, and compassion. You technically, you can do this with a landmark technique. We have done it for many years, but when I think about having something that improves patient experience, decreases adverse events, and really allows us to do a better job. I'm really excited about those opportunities and to see how this impacts our practice. And with that, I'll take some questions.
Thank you so much, Dr. Gallin. I think there is a question in the Q&A box down there.
Oh, okay. Yes,
Yeah, if you
Q&A
can see
box.
it.
Thank you. Great. We have a question. I'll just read it out loud. It says, I
Yeah.
completed my fellowship in 1997. Ultrasound guidance, regional anesthesia has passed me by. Please recommend where is the best place for me to gain proficiency. I've maxed out the workshops. That is a great question. I think that's um, a common question. Uh, Resources include, there's a wonderful up-to-date article written by actually a mentor, Brenda Camdar, where she maps out the basically what landmarks to look for and how to do an ultrasound guided um, epidural. I think as we think about what is ultrasound guidance, right now it's really pre-procedural mapping. If you use a standard ultrasound probe, so you're going to turn it one way, you're going to make sure you know the proper level, then you're going to turn it the other way, and you're going to try to figure out um, uh, the midline, any curvature. And my recommendation would be workshops are wonderful, but you just need to do more. So continue to scan people and try to figure out where kind of X marks the spot. But really, this is where the Acura device becomes incredibly helpful, which is it gives you that 3D image um, of the spine, and it makes it so um, you essentially kind of know where you are in space, and it really converges all of those skills that you've learned in your workshop. I'll let Steve speak to the new 3S system, which is even more exciting. That gives you the real-time guidance. But I think that this is where the technology, you know, despite going to a number of workshops, it's still really hard. And this is where I find that these devices can be incredibly helpful in terms of flattening that learning curve. Steve, do you want to jump in for a second?
Yeah, no, I think yeah, the workshop's obviously a great idea. And yeah, and then for the 3S portion, don't know if there's anything specific about it that I could shed some more light on. We did get FDA approval over the summer, which was really exciting for us. Been working on that for a while. And really looking to more into probably this time next year, give or take. We're kind of slow rolling, making sure we're bringing this product to market that has everything that everyone's been asking for. It's really a lot of trial and error and clinical sites where we'll be working on. But yeah, if there's anything specific, can certainly answer, more pointed questions, or, if you think of any over email, you can always let us know and we can kind of direct you and just give you some more updates that way. But yeah.
Great. Thank you. Wonderful. Next question, is ultrasound usage the best way to minimize post-sterile puncture headaches? That is a great question, and one that I will say I don't have um, a comprehensive study that says yes or no. But at least in my practice, when I think about wet taps, it's not knowing um, where you are in space or moving too quickly, to the epidural space and kind of overshooting. And so that's where I'm most excited about this real-time ultrasound, is because as you approach the epidural space, and you approach the dura, you will see yourself. And so that's why I'm optimistic that this real-time ultrasound will decrease the post-sterile puncture headache rate. Again, RIVANNA is doing a number of studies now to look at the specific effect of their 3S products on post-sterile puncture headaches. So I'd say stay tuned for some really exciting data that hopefully is coming out soon. But again, as I think about kind of the most similar procedure I think about is looking at nerve blocks, right? So we used to use nerve stimulators, and there were some nerve injuries, but now that we have real-time guidance, we can see as we're approaching something that's a danger zone. And so I think about um, ultrasound guidance in the same way. If you can finally see what you're doing, and hopefully avoid any complications. Okay, we have some questions in the chat, other chat. We have, I've owned the RIVANNA since 2023. Is there a newer version? You keep mentioning AI assisted. The patient who had unhealed fractures in the previous car accident, would you strictly use the RIVANNA to guide your guidance or other imaging for guidance? Okay, two-part question. Steve, I'll let you talk about the 3S and the AI assistance.
Yeah, excited you've had a device. I hope it's all going well. Yeah, what I think kind of the next generation, and we're looking at the Acuro 3S, is really just a more robust version of Acuro in terms of its AI capabilities, identifying bone anatomy, muscles, and these kind of soft tissues, uh, and just along with the needle tracking. So just a lot more robust, I would say, than obviously the Acuro, just the small handheld. So kind of moving in to that space and being able to do something real time. Uh, everyone's obviously been asking for that, so we're excited to kind of get that to the market. Um, but yeah,
Definitely. Excellent. And then you said the patient who had the unhealed fractures from the previous car accident, would you strictly use the RIVANNA to guide you or other imaging for guidance? I would say this is where imaging is helpful and the RIVANNA device is even more helpful. So she had a lot of scoliosis. And so we use an ultrasound. I actually didn't have the RIVANNA device at the moment. We use an ultrasound for guidance to understand the appropriate level and the appropriate curvature. But this is the moment where I would love to have kind of that 3D reconstruction of the spine to not just say, okay, I know this is L3, L4, and I know there's a 30-degree turn to the left, but I don't really understand where I am in space and how, where's the spine is processed above and below. And so that's where I find that I'm most excited, which is, to have a device that merges not just traditional ultrasound technology, which is this is the anatomy, but really thinking about how does that 3D reconstruction and the real-time guidance help me even more. Okay. Next question. What is the learning curve to implement Acura or 3S in our practice? It's been interesting to have one, and I've taken two approaches with different people. Some people I teach and say, let me show you how to do it. Other people, I leave it in the corner and I let them be curious. And what's interesting about those two experiences is that the learning curve is actually very flat. It's super easy to use. You pick it up, you can put it on a back, and all of a sudden you have this image. And so it's very user friendly. Understanding how to then merge that and do the procedure takes a little bit of guidance just as we think about changing the way we think about landmark versus ultrasound guided techniques and think, where do I put my needle and how do I kind of mentally make this picture in my mind. But to actually use it, you turn it on, you put the gel on, and that's it. It's really user friendly. And so I'd highly encourage you, if you're interested in trying one, to try it out. It's really kind of low stakes and very easy to approach. How does Acura compare to Butterfly, or is it essentially the same product from different companies? Excellent question. I love that we're all using kind of more point of care ultrasound, and we're comfortable using Butterfly or Philips or whatever company you use. This is where Acura really shines, which is it's not just showing you, a 2D image of what you're looking at. It's really giving you kind of a more kind of 3D reconstruction of a spine, helping you understand where you are in space. And so it's an extra level of guidance that makes it really attractive. All right. I love these questions. Any more questions? The other part that I like about the device is I think about I used to be in an institution that had glide scopes for intubation, and it we didn't have it was hard to transport around different ORs, but with the Acuro, it's small. It fits in your pocket. You can bring it around really easily. It's quite portable, and so oftentimes I leave it in my pocket, and if I'm having trouble with a procedure, I just take it out and I take a look. It's really easy to hand to a colleague. It's very kind of user friendly, and there's very low stakes to using it. And so that's one of the other benefits. Just it's very user friendly. Wonderful.
Okay, so
Any other
um,
questions?
yeah, let's give a one final chance here if anyone has any other questions for Dr. Gallin. Okay, well, I am gonna take that as a no. But anyway, just to round things off, Dr. Gallin, thanks again for taking the time to present for us here today and answer all these questions. We really appreciate it, and we appreciate your expertise on the subject matter. For the attendees that are still here, this program will, it is being recorded, it is being transcribed, and that was a question earlier. So you will have access to this later on, um, whenever you want. So with that being said, I think that's going to be it. Thanks everyone for attending. I hope this was informative and you learned something about the developments in the field and the technology that's out there. And without further ado, thanks everyone for coming.